All right, looks like we're 2 minutes past the hour, so I think we can go ahead and get started. Again, welcome to those who have joined us this morning. Good morning, good afternoon, good evening, depending on your location. On behalf of the Boost and Ariadne Labs team, we're very excited to have you join us for this bi-weekly conversation on the role of community engagement in building vaccine demand in mass vaccination sites. So before we get started, just a few housekeeping items we'd like to go over. Please be sure to mute yourself when you're not speaking, to limit any background noise and feedback. Feel free to use the raise your hand feature or the chat box option at the bottom of your screen to share your questions and or comments. And like I said earlier, please feel free to test the chat function now by sharing your name and where you're joining us from. Just a quick overview of the Boost community. Again, it's a global community where immunizations are able to connect with each other, access learning opportunities, and lead within their context. Feel free to visit our website, boostcommunity.org, to learn more. And just a quick run through of the Global Mass Vaccination Site Collaborative. This is really a collaborative aimed at providing resources, tools, experts, and guidance for those who are leading mass vaccination sites efforts within their countries. We do have an open access website as well as a learning group, so we do encourage you to visit those to access some of those resources, learn more about upcoming events as well. And great, before we actually start the session, we do have a poll question that we would like to launch. Just wanting to get a better understanding of community engagement strategies being used in your community. So which of the following strategies have been the most effective in increasing COVID-19 vaccine demand in mass vaccination sites within your country? So you should see the question pop up on your screen. Please feel free to answer. I'll just give about 30 or so seconds for that.
Okay, let's, I can just share the results. Okay, live. So which of the following community engagement strategies has been most effective in increasing COVID-19 vaccine demand in mass vaccination sites within your community? 50% said engaging across multiple accessible channels, and 50% said forming partnerships with community organizations.
Thank you so much, Jen. Great. And with that, I would like to present today's speaker. Very excited to hear about everything that Robert has to share. Robert Kamwagi joins us from the Demand Generation focal point at COVAX and Gavi. So very excited to hear what you have to share, and I will hand it over to you, Robert. Thanks.
Thanks, Yvonne. Hope you can hear me. Let's go to the next slide. Yes, I'll try to present the lessons based on this outline. You can go to the next slide. So I think one of the common statements in one of the most recent articles in the papers, one of the most common words or statements that has been used frequently in the last 2 years that appears a lot in newspapers and in various media is the word hesitancy. And I wanted to share with you some interesting findings by IPOS, which show that a great percentage of people in some countries in Africa are actually very willing to get vaccinated. As you can see, the DRC, one of the countries that has low vaccine uptake on the continent, in fact, less than 1% coverage, has about 60 people out of 100 who are vaccinated or willing to get vaccinated. That's a very interesting finding for DRC, for those who have been following it for some time. But you can see that on average, more than 70% of people in these listed countries within Africa, including Nigeria, which is another priority country, are actually willing to take the vaccine. Let's go to the next slide, and then you'll see why I wanted to share this before we go into the conversation. But when you compare this with the current vaccine coverage in 34 countries that COVAX is focusing on, you can actually see that even in countries where we have high vaccine acceptance, like Cameroon, which is at 40, DRC, which is at 60, Ethiopia, which is about 80. When we talk about coverage, the coverage is still low in those countries. Even Kenya and Uganda, which have high acceptance, is still low, 3%. So it then begs the question, are people hesitant to take the vaccines, or are the vaccines accessible? And then this, if we ask ourselves these two questions, we come into discussion what the role of community engagement would actually be in setting up mass vaccination campaigns if we know that a certain country has a high level of acceptance or confidence in vaccines, but very low coverage. In Uganda, for instance, there's been a vaccine wastage in December of last year of 400,000 doses of Moderna. And the uptake has also not been to speed as it would have been expected. So then what explains the difference between high willingness to get vaccinated and low uptake? And what role can then community engagement play in scaling up vaccine uptake when you talk about mass vaccination sites? Let's go to the next slide. Next slide, please. So there is a very important word in mass vaccination site. I've marked it really. It's the word mass. In principle, you may have a vaccination site, but it doesn't have to be. It doesn't necessarily mean it is a mass. You can see the big tent picture I've put there. That's a big vaccination site, but it does not mean it is a mass vaccination site. Those are two different words. Having a big structure or a large structure does not mean that you actually have a mass vaccination site, because the word mass in that strategy or statement is meant to mean majority, a gathering, people, trust around a service delivery system. So we might concentrate on setting up beautiful structures like the one you see in that picture, but you might miss the role of the community in creating what we call a mass vaccination site. So without the people, you may have what we call a vaccination site, but not a mass vaccination site. Then the other question I want us to reflect on as we discuss, how do we expect mass vaccination sites to be massive without the community participation and involvement? How have we had mass vaccination, mass service delivery sites before COVID-19? Yes. Some of you know that we have had sites for safe medical circumcisions, which have been massive, family planning provision, massive voluntary counseling and testing, routine immunization. All these are service delivery sites that have existed, but you could say massive in the communities. What have we learned from the previous mass service delivery sites? Next slide. So I picked this from the US CDC approach. As you know, the US has also set up several sites for vaccination. And in the forward for that document, they say the federal government, in partnership with the state and local governments, will create as many venues for vaccination as needed in communities and settings that people trust. The last two words are very critical in the role of community engagement in mass vaccination sites. It's not simply setting up a site, but you must ensure that people trust the site. So for that trust to be obtained or to be achieved, there must be a relationship between the service delivery site and the community where it has been set. This is something that we continuously forget when setting up mass vaccination sites. Continue. Please, next slide. So I decided to divide some of the lessons learned or technical recommendations on how to set up community engagement and well integrated into mass vaccination site into 3 buckets. The first bucket is the before or the preparatory stage. Preparatory stage is usually one of the most missed stages in pandemic responses. Why? Because many people go to deliver the services with less preparation. And as we start to deliver the services, we begin to learn what we have forgotten or not done to ensure that we are well prepared to provide services. And therefore, we encounter a lot of challenges during the service delivery time. So what have we learned from the Ebola vaccine deployment programs across the continent? These are some of the things that we learned, and these are some of the things that were done to ensure that good preparation was made before a mass vaccination site was set up. One, it is critical for you to conduct assessment of the political environment and government buy-in. It's not a thing when the Minister of Health says we are ready to conduct vaccination, and then you go down to the counties or to the districts or to the lower government structures and you encounter challenges, but it is the same government. So the importance of doing the assessment for political environment is to identify stakeholders at local and national level. Yes, you have a sign-off by the Minister of Health. Yes, you have the sign-off of the technical people within the government. Do you have the sign-off of the county or the lower communities in terms of their political buy-in and involvement? So that's very critical for setting up a mass vaccination site from a community engagement perspective. Second one, once you have obtained political buy-in at regional, local, and government levels, including opposition stakeholders, you have all seen that COVID has become political in terms of vaccine rollout. So part of the government that usually is not consulted are those who lead the opposition to the government. Because sometimes politicians use opportunities for pandemic response to create resistance against government programs. So it's not only the government that you should target. We did this extremely well in DRC. We did a political mapping when we were deploying the Ebola vaccines. We not only reached out to the government stakeholders, but it was also very important to identify the opposition within those communities that we had to work with, and then had good conversations with both forces. Second thing that is critical as part of the before and after, before preparatory or the preparatory stage, is to perform a robust assessment of the socioeconomic structure of the localized population to identify at-risk groups based on the variables of age, behaviors, etc. Establish the local consensus of target communities to understand their needs. Do you know this, or are you simply going in? For instance, when we were beginning COVID-19 vaccine rollout, the target was the elderly, healthcare workers, and people with underlying medical conditions. So where you are putting the site, does it have the target population, or you're simply dropping a site where actually you have maybe 1% of the target population in the coverage where you're putting the site? Meaning that the majority of the people that you would have been targeting are actually 5-10 kilometers away from the mass vaccination site. Therefore, you now bring in a problem of access, because then the actual target for the service is not near the service. The second thing is establish a list of core program implementation stakeholders. You need to do that before you do your mass vaccination programs from a community perspective. Do you know them? Are they trusted? Are you using them the way they should be used? I'll give you a good example. In Sierra Leone during the Ebola outbreak, we identified a young man who was the leader of the youth leadership and governance of a local district. And when he was identified as one of the key stakeholders we were going to work with, the community gave us feedback and said, we don't trust him, so he can't be part of the stakeholders that you should use in creating vaccine confidence for the rollout of Ebola vaccines in our country. So if we had not consulted the community, we would have gone ahead, had him as one of our champions, and the community would definitely have rebelled against us. Do micro plan for implementation, establish local community level intervention approach, and then the other thing that you need to do is to conduct a complete infrastructure and visibility assessment. And here I want to focus mainly on technology. We're in a world of technology. Where you are putting the mass vaccination site, what is the infrastructure capability? Is there electricity? Is there internet? Is there wireless? What is the nature of the technology that can enable you as a facilitator for that site? Strategically select vaccine site locations to match the demand of the target population. I've already said this. So from the bucket of before, those are critical considerations from a community engagement perspective that you need to plan for and put into perspective. Next slide, please. Again, related to bucket one, next slide, is another critical considerations. Consider assessment of staff and manpower needs and capacity. The health center one in many of the African countries is the community health structure. The community health structure is responsible for educating and mobilizing communities to go and get services from the health facility. It's very critical that you do an assessment, a community functionality assessment. And these don't need to be detailed assessment. In BSC, we had a rapid assessment tool, a very simple Excel tool where you tick yes or no, and then you know, okay, I am going to this community. It has target audiences for the vaccine, but they don't have a functional community health structure. They don't have community health workers. They have struggles with having nurses or other medical healthcare staff to be available. Have you done that? You do that assessment? Do they need training? Can you provide the necessary training? Even the community health workers, can you give them the necessary training so they are aware of what they need to communicate? Can you also do staff scheduling? Because when the sites become busy, the reason why you'd ask, why is staff scheduling important for community engagement? One, if the sites become busy and the health center staff are overwhelmed, they will ask the people who have come to be vaccinated to go back and come back the next day. Now, that's a driver of lack of trust. Remember, you promised somebody to go to the facility to get vaccinated. If they reach there and they're sent away, you're losing trust between the community and the vaccination center. So there are things that we have to do from a health facility level that are intentionally meant to build trust with the community. We are meeting the promises that we offer the community when to mobilize. Consider funding options. What resources do you have, or do you have a budget to support community engagement as part of the preparatory stage? So there is consistency, you know what is going to be done in terms of the implementation. Ensure the safety of the vaccination campaign staff. This is very critical, again, as part of trust, as part of relationships with the community. The last thing you want to do is a person going to the facility to be vaccinated and they get infected at the facility because somebody who's vaccinating them is not well protected. That is likely to lead to spillover effects in terms of conflict in the community. Assess the availability and the strength of the wireless mobile coverage. I've talked about this. We did this in the Ebola vaccine rollout. We mapped this and we were able to know how much of the technology will be used because we used mobile phones for one, for scheduling of participants. We were scheduling participants in the community. The community health workers would come to my home, educate me about the Ebola vaccine, ask me if I was interested in taking the vaccine. And then they would ask me what would be the best day for me to go and get vaccinated and which site would they want to go to, which of the mass vaccination sites would I want to go to. Then using my mobile phone as a community health worker, I would schedule them. I would schedule my household participants and therefore make them aware which place or site they would go to and what time. When I schedule them using my phone, this message would go to the healthcare worker who's managing that site. And in the end of the day, they'll be able to run what we call the appointment schedule for the next day and for the other day. And then the same message would go to the person who has scheduled the appointment. So scheduling is important. One, it allows participants to arrive at the facility at the time they need to arrive, but also allows them not to lose time when they go to the facility and sit, because what is it that will undo our community engagement is the length of time people spend at the facility. So can you plan for scheduling of participant that is community-based? Next slide, please. So this is the example of the tool that we use. It's called the Gap Analysis Communication, Community Engagement and Compliance Tool. We developed it using during the Ebola outbreak. It is the tool that we use to do what we call the preparatory stage. So you can use this an abridged version, which is a rapid assessment tool, and then there is the more lengthy version. It's a very nice tool. We did this for Ebola. When we did it, we didn't know that there would be COVID-19. You can see it's 2019. We didn't know that there would be an outbreak. We started working on this tool in 2014, and we used it in 2014, 2015, and 2016. But we published the final version in 2019. This tool was developed to help implementers on how to conduct rapid gap analysis in communities, in country, or health systems to better understand the key things from a communication, community engagement, and compliance perspective that they need to do or put into place before they establish a vaccination site. It's a tool that is available to you as participants that will be shared. You can look at it. Those are the things that the tool does. So it's a critical resource for preparedness that I've been describing. Next slide, please. Now, one of the things that I talked about is site selection during bucket one of preparedness. You simply don't pick a site because somebody has given you a venue where you can put a site. It is always good when communities volunteer venues, because then you're not paying any money for them, or the community feel they are part of the process. This venue selection also needs to be informed by a preparedness or a rapid assessment to understand this is the area where we have many people who we are targeting to get vaccinated. And therefore, and this area has good internet connectivity. It is within reach 2 to 1 kilometer of a population of 3 million people who are targets to get vaccinated. And therefore you select the areas. You can see here in DRC, we selected North Kivu was where we are working, and then we are also doing the vaccination across the border in Rwanda. So we selected sites, 2 mass vaccination sites in areas that were cross-border, that were both in DRC and in Rwanda, and therefore we could get many participants, because these are also areas where the transit immigration points were in both countries. So be mindful about where you select to have a mass vaccination site. Next slide. So next slide takes us to bucket 2. Okay, before I conclude bucket 1, I want to emphasize that preparation is very important. So make use of your understanding of the landscape. That's all you do. You have done the assessment, you know the issues, plan, make use of that information. It is common today during COVID-19 that we collect a lot of data but never use it. It's an observation. Develop your mass vaccination site recruitment strategy. There is a difference between having a community engagement strategy and a mass vaccination site recruitment strategy. These are totally 2 different things. The communication and community engagement strategy is your strategy on how you're going to engage the participants or the communities. But the recruitment strategy is how you are going to ensure that people are coming from the communities to the site. And there are people responsible who know how to refer, schedule, and the schedule participants or communities to the site. And at the site level where the vaccination is happening, they are aware of who will be coming that particular day, at what time in terms of numbers. So you have a clear plan of how people come to the site. Cost your strategy and have it funded. Sorry about that. Make sure that your strategy is funded. It is very common to begin communication and community engagement, and then it ends midway because you don't have funding. But you've started engaging the community. You don't want to lose a relationship you've created with the community, because the moment you lose that relationship, you have lost the trust. People will not come back. Have dedicated staff to manage community engagement strategy and relate with the community. The goal of the preparedness phase is to ensure community ownership and build trust. Only through community ownership and trust building shall we transit the good structured vaccination site into a mass vaccination site. And that's what I was showing at the beginning. Next slide, please. So now, the next slide is bucket 2, which is basically now the implementation stage. Now you are vaccinating. What are you, how should you go about it? Establish formal community engagement plan. I talked about it. You start implementing that plan. That's during the implementation. And those are some of the key variables to think about when you are implementing a plan. Use evidence-based behavior strategies and interventions. And ensure that the interventions you are using reduce travel burden. Because one of the biggest things we are seeing with COVID-19 vaccine uptake is access, hiding behind hesitancy. Therefore, we need to come up with strategies that will ensure that we are reducing the travel burden. Next slide, please. So, three critical things to think about from a behavioral intervention. Identification of rumors and misinformation from the start of the large vaccination campaign or site. Now, every time we talk about rumors and misinformation, the first thing that comes to mind for many practitioners is social media. Yes, but now if you have a remote vaccination site somewhere, let me say in Marsabit in Kenya, or in Narok, or in one of the remotest counties, Wajir, let me say. How will you be able to identify what rumors are circulating in that community? Because the rumors that circulate in that community are the rumors that are important to sustain a relationship in terms of knowledge, but also in terms of fears. So the high-level rumors that appear in social media may not be the ones that communities in Wajir are talking about the vaccine. Maybe in Wajir, the fear is about they will lose their animals or something like that. Somebody says, if you get vaccinated, this is what will happen to you. You can transmit this too. So you need to establish a community offline social listening system. We did this in DRC. We used the community health workers to identify rumors by being in the community. We used to call them standing agents. Their job is to stay in the community and listen and hear what the communities think and are talking about. Once they identify these issues, they are reported through the mobile phone, the mass media platform, the social listening platform. And at the end of the day, there's a dashboard where you can actually see what each of the community health workers is reporting as a rumor from their community. So do you have that system that can identify what is it that is creating fear in the community? And how can we address those fears? Because those fears are the obstacle to people coming to the mass vaccination site. 2, do you have a community feedback structure that when you identify these fears and misconceptions that are coming through the community, you are able to go back and communicate and address these concerns? Do you have that? You need to plan for it, the role of community engagement in mass vaccination site, because you cannot sustain the vaccination site to be mass if there are fears that you are not addressing. Establish local appropriate strategies. Language, respectful community attitudes. Are you doing this? For instance, there are very basic things. There are cultures where only male healthcare workers can attend to males and females can attend to females. Have you taken advantage of that? Or do you think that women will go to male healthcare workers and men will go to female healthcare workers? If you're not addressing that, that is a put-off. Motivation and incentives. You need to think about your community health workers. What is it that you have put in your mass vaccination campaign strategy and in your community strategy to ensure that they are motivated? Next slide, please. Next, okay. Now, the other thing which I want us to pay attention to is the role of technology in mass vaccination campaigns. It's a very big tool. One, I've talked about it as part of preparation. You've done your assessment. Are you using mobile technology as a tool for program design? It could be messaging. We are now talking about 2-dose vaccines. What we did in the Ebola vaccine trials, we used a system called MOTEC. Basically, when you come for your first dose, we register you, and then we are in contact with you remotely through phone by a message. You have received your first dose. The next dose of the vaccination will be on this. They give you an exact date when you will return to the mass vaccination site to get your dose. But one of the things we also did is to keep in communication with the vaccinees, continue sending them messages to remind them of the behavioral practices that would prevent them from getting Ebola. So it's simply not only about the vaccine, but what does a vaccinated person need to do to remain free of infection and to be protected? So it was a technology strategy that gave us continuous engagement and interaction. The rest you can see. I would like to go to the next slide. I want to talk about monitoring as under, again, bucket 2, that's again during implementation. And I want to focus mainly on monitoring a variety of metrics or categories. The first one is you have to monitor severe adverse effects. It's very important that from a community level, you are identifying, or through your community health workers, you're able to identify or if there are any people who have suffered severe adverse effect as a result of the vaccination. Very critical, because if you don't do that, then you risk having this as an obstacle to vaccine acceptance. So monitoring is important. So monitoring behavior determinants, monitor engagement of community education, monitor behavior outcomes, etc. So have a monitoring component of the behaviors of the people in the community, of the effects of vaccination in the community, and use your community structure to address the concerns that are coming up. Next slide, please. Next slide. So lastly, which is bucket 3, is close out. You have now vaccinated the entire population that was your target in the catchment area. you document your best practices during implementation, create a set of evidence for best recommendations, take stock of the HR resources, including community health workers that have been trained, conduct community feedback meetings, celebrate, and many other things that you can do in a closeout. I think the next slide is questions. Thank you.
Great, thank you so much, Robert. We do have a few questions that are coming in, and I'm not sure if you have access to that, but first question is from Emmanuel, and his question is if this movement is going to assist in a different way, aside the current strategies and planning of various organizations in the country using the COVID-19 vaccination. And Emmanuel, if you're still on the call, please feel free to get off.
Yeah, I'd like to get some clarity. I don't think I've understood the question. Emmanuel? I don't understand what the movement would be.
Okay, he might have
Do you understand?
No, he might have just hopped off the call, but I can go on to the next question. The next question is around.
Sorry, I think I could maybe clarify what he was trying to say, which was just, I think when thinking about this kind of strategy, Robert, from the kind of Ebola perspective and translating that to COVID-19, do we think that these kinds of tools will be assisting in a different way aside from current strategies? I imagine it'll depend on what country you're in and at what level in the system, but I think just maybe understanding where there are some congruencies or threads that tie into the existing strategy that folks in countries are using and how this may differ a bit.
I think the strategies as outlined in the recommendations I've just shared can be adopted or adapted for COVID-19 vaccine rollout or any other vaccination programs. For instance, that gap analysis tool that I've just shared, we developed it originally for Ebola, but some countries and some organizations have actually used it to do gap analysis for COVID-19 because the health infrastructure in terms of community is in what we are looking for, and Ebola is the same as what we are looking for under COVID-19. So it is possible to adopt or adapt some of these strategies.
Great, thank you. That makes great sense. And Yvonne, I'll chime in because I know one of the questions was also for me. And I was just curious for the gap analysis tool. I think we have folks on today, and I'm sure folks that are listening to the recording from like a national level to a subnational level or a CSO or implementing partner that's working in a local area. I'm just curious, Robert, one, thankful to have you here today. And curious how, I know that we'll be able to share out the tool that you've shared here today with the community, but how the different types of folks who could utilize it. And I know you touched on this a little bit, and I think initially been used for implementing partners, but just kind of curious about some of the use cases for the analysis tool in different levels within a system in a particular country.
So the gap analysis tool can be used at it has sections that are appropriate for national level, but it is a very good tool for sub-national level. So in terms of getting the minute details which are critical for planning, for communication and community engagement for mass vaccination site within that local setting, because the purpose of the site is to address vaccination needs within the setting where it has been set up. Therefore, what you want to understand, one, is the assets and opportunities that exist within that community. Then two, what are the gaps that exist within that community? The moment you get information about what are the assets, the opportunities, and the gaps within that given community, then you are able to address the gaps in that given community, because it is the gaps within that given community at subnational or regional that impact the success of the mass vaccination site, is what makes it mass or simply another walk-in site. So you can use it at district level. For instance, people on the call from Uganda, you can use it. If you're from Nigeria, you can use it at a state level. If you're from Kenya, you can use it at a county level to better understand the context. But it also has a section which evaluates the readiness of communication and community engagement from a national perspective, because policies, guidance from a national perspective definitely have an impact on what happens at subnational and regional. For instance, technical support, or if there are any policies or training guidelines that are being developed at country level, but you need them to use at your communication and community engagement levels of the site. It's a very good tool. I would recommend the participants to look at it.
Fantastic. We will make it available to everyone. Thank you. Thank you, Robert. I guess I have one other question just from me, and then I'm sure others, please do chime in or raise your hand, is just around, I mean, we've been having conversations, a lot of conversations around how we define mass vaccination sites and, you know, throughput per day, population size in the surrounding area, and just kind of curious, when you use mass vaccination site terminology, what is the threshold you're thinking of?
In DRC, our daily target vaccination was between 25 and 50 people per day. Because we need to appreciate that there are also limitations to the site. So not everybody will come in at the same time. There are also human resource challenges. But the goal is that if you set up a site, a vaccination site, it only becomes mass if it is bringing in people. And it only becomes mass if the return or the number of people coming in to get vaccinated are much higher than the number of people that go through your routine small health center 2 or 1 or 3 in a given community. So the expectation that you'll see more people than what is expected. But if there are no people, then it is difficult to say you are operating a mass vaccination site if it is seeing less than. There's no need to set up a mass vaccination site if you're seeing less numbers than those that are being seen daily at a health facility. Then allow the normal health facilities to run the vaccinations. The other one is it should be able to reduce the access issues, distance. In where I come from, many health facilities are between a radius of 3 to 5 kilometers. If you're bringing a site that also gives me a radius of 6, 7, 8 kilometers from where I am, it is not solving the issue of access. So mass vaccination sites should ultimately solve the issue of access. So those are 2 things that I would look at.
Very, very helpful. And that access point, I think, is so key. Hand it back over to you, Yvonne, or if there are others that have questions, please. I see different folks that are on that have joined us previously, so we'd love to have you chime in.
Great, thanks, Jen. Yes, please feel free to either raise your hand or share your questions in the chat box. But for now, if there are no other questions, I guess we can move to the next slide. Just a few housekeeping items. Thanks again to Robert for a really, really great session. I think it was very engaging and lots of great information here. And as mentioned earlier, we will be sure to share all additional resources from this session with everyone in a follow-up email. So please be sure to join or visit the Boost community at boostcommunity.org, where you can access the Global Mass Vaccination Site Learning Group and other resources relating to mass vaccination site operations. We do also have the Mass Vaccination Site Open Access website, globalmassvaccination.com. We are constantly updating that website with resources and tools around mass vaccination sites. So we do advise you to visit that site and learn more there. And last but not least, we do ask that you please take our survey, just a brief 2-minute survey. Really do want to hear feedback from you on how this session went, and really helps us kind of improve future sessions. So we do ask you to do that right after this call. But again, thanks to Robert, our speaker for today, for an engaging session. And thank you all for joining us today. And I hope you have a wonderful day. Thanks, everyone.